Welcome back to Baba Yaga of Airways, Part 2. There are more cases of lingual tonsillar hyperplasia. I'll talk about a couple more cases. Okay? So, Adrian Madiak from Madison, Wisconsin, and Olson in the Canadian Journal of Anesthesia in 2004 described in an article two cases. Two case reports in the same article, in which they needed to use a novel at that time, a supraglottic airway that I use now, called the King LT. In the two cases, there's some similarities and differences. Okay. In the first case, there was a 71-year-old who was around 6 feet tall, 244 pounds. He was in for elective surgery. He was going in for a right thigh surgery exploration of a wound that developed from a femoral pop bypass in that same 3 weeks earlier. There was no documentations of a difficult airway then. Pre-op was done for this patient. You notice he had a large tongue. He had acromegaly-like features, but no documented history of acromegaly. Mouth opening, at least 3 finger breaths. He had no teeth. Mallampati on him is a 2. Mallampati scores used to help assess for difficult intubations. So his was a 2. So was this class 2. Okay, part of the tip of the uvula is being covered. Okay. Thyromental distance from the tip of his chin to his thyroid was 6 centimeters. He had good neck extension. So they presumed he was not going to be a difficult airway. They gave him fentanyl, propofol, and succinylcholine. That's when they noticed he was kind of difficult to bag. But the medicine's already in. They failed with a Mac blade, a regular size, 3 Mac blade. And they noticed again that it was difficult to bag. So they went on to putting an LMA in him. Didn't succeed in bagging him correctly. Failed rescue oxygenation. So they pulled it out and put in a King LT. There they will oxygenate the patient, and then they actually try to look through a fiber optic scope through one of the openings on the King LT, and they could not visualize the glottic opening. Because this is an elective procedure and they were now successfully able to ventilate the patient on a ventilator, they proceeded with the rest of the case. The patient had already fasted, so they proceeded with the rest of the case, and they finished the case with no complications. Later on, an ENT doctor, an otolaryngologist, did a direct laryngoscopy and fiber optics, and was able to document that the patient, along with having a massive tongue, had lingual tonsillar hyperplasia, likely causing why this gentleman, when they were trying to intubate him, had a Coromac score of 4. Basically, the same tip of perhaps the tip of the epiglottis when you intubate, but mostly all tongue. The next case that Madiak described, I met him at the SAM, Society of Airway Management conference. Good, humble person. Very nice. I learned more from him than most people, than from the rest of the workshops. No offense to the SAM, but I learned from him, to Kanto. Great thing to join if you wanted to join. Basically, a whole bunch of airway nerds or experts or gurus. But the stuff, people love the subject, and you learn so much. The next case, a 50-year-old, 5'7", 606 pounds. Elective surgery? Yes. Bariatric surgery. Patient has, of course, diabetes, insulin dependent, morbid obesity, obstructive sleep apnea, hypertension. This patient was predicted to be a difficult airway. They plan based on the patient's just past medical history. Now, they did a routine workup checkup on this patient, and no clinical signs of airway obstruction, other than this history that suggests he may have it subclinically when he goes to sleep. Mouth opening was adequate, at least 3 finger breaths opening, but morbidly obese, short, fat neck. The distance from the chin to the thyroid, where they presumed was thyroid cartilage, only 3 finger breaths. Mollen-Party score was better than the first person, who was less obese or less heavy. Mollen-Party score was 1. Okay. Mollen-Party score was 1. You can see the entire uvula. See? The patient had limited neck extension, secondary to the pannus in the back of the neck. Okay? This patient was ramped up, super positioned, head elevated, head above the shoulders, above the neck, ramped up. This was predicted a difficult airway. He still gave propofol and sucks. The patient's all ramped up. Something interesting, though, is once they gave the medicine, she was kind of difficult to bag. Okay? The medicine's already in. Proceeded on trying to intubate with the MAC blade, DL blade. Cormac score of 4. Again, when you see only almost all tongue, or tip of perhaps the glass. So this patient was hard to bag, and they proceeded to use a King LT. Now they used the King LT to oxygenate the patient up. Again, they tried to use a fiber optic to see if they could see glottic opening. Glottic opening meaning the vocal cords. We're going to go past the tube. He saw almost nothing. Poor visualization of anything. So they let the medicine wear off, and the patient woke up. And what was suggested to this patient is, we'll reschedule this, but we'll do this awake intubation fiber optically through the nose, because we suspect that you're going to be a difficult airway again. And surgery proceeded without any complications, fiber optically through the nose, uncomplicated intubation, and the patient had a bariatric surgery. All right. The last case I'll talk about was by Kwan, the Korean Journal of Anesthesia. In 2013, we're talking about the difficult airway management in a patient who has lingual tonsillar hyperplasia and TMJ ankylosing or stiffness. Okay, this patient was 5'4", around 140 pounds, more than 140 pounds, and was getting elective surgery for a cyst removal in the jaw, in the mandible. Patient had a history of controlled hypertension, some TMG disease. Mouth opening was 4 centimeters. 4 centimeters. Mollen-Party score was 3. Right. So remember, you can theoretically have a Mollen-Party score of 0, see uvula and also the tip of the epiglottis. His was not a 1. His was not a 2. His was a 3. So despite being the thinner of all the patients that we're talking about, his was a 3. All right. You could barely see any parts of the uvula. Okay. Limited neck movement. From what I'm not sure, but we had a limited neck movement on assessment, and the distance from the tip of the chin to the thyroid was 6 centimeters. The anesthesiologist proceeded and given him some lidocaine, fentanyl, propofol, and rocuronium. Guess what happened? So when they bagged him, they noticed it was difficult to bag, and his cheeks would blow out. All right. But they were still able to oxygenate him somewhat. They proceeded, without any desaturations, to DL. Cormac score of 4. Again, almost all tongue. Maybe the tip of the epiglottis visualized. Again. Bad score. Now, Mollen-Party scores sometimes correlate with a bad Cormac score. Not always. So, they failed with DL blade. She's kind of supine on a ramp. Then they try a fiber optic scope. They see a lot of soft, redundant tissue at the base of the tongue enveloping the laryngeal blade. So what do you think? When you use a fiber optic scope through the nose or through the mouth, you're going to see gravity allow this mass or lymphoid-like tissue to still obstruct your view. So they pulled out the fiber optic scope, and guess what they did next? Use a laryngoscope, pulled up as much of the soft tissue as they could, and through a fiber optic got around all that excessive redundant tissue, and they were able to intubate with the fiber optic scope with the DL blade holding it up. Quick thinking. Okay. No documentation of hypoxia, and they were successfully able to intubate this patient. They were able to do the procedure, and later on, with direct laryngoscopy by an ENT doctor and CT surgery, they found that he had massive lingual tonsillar hyperplasia. So, 3 other doctors were witnesses to this lingual tonsillar hyperplasia, the Baba Yaga of Airways. I'll welcome you back to part 3, talking a little bit more about lingual tonsillar hyperplasia. Thank you.